Oh, it's 10:30. Do we have a... All right, to get started, Julie?
Yeah, fine, absolutely.
Okay, well, good morning, everyone. Welcome. Julie, you're going to do the new governors in a minute, aren't you?
Yeah, no, we've got a few changes, yeah.
Okay, all right. Apologies, Julie?
Yeah, I've got apologies from Deborah Alcott-Tyler, Patrick Clark, Megan Wright, who's our new Bracknell Forest councillor representative, Sarah Croxford, Graham Bridgman, Raldolph Sion, Tom O'Kane and George Matthew.
Okay, all right, thanks so much. Okay, declarations of interest. Okay, 4.1 minutes of the last formal meeting and the minutes of the extraordinary meeting. Any corrections, please? No? In which case, item 5, uncontested public governor election. Julie?
Yeah, so it's welcome back to Deborah Baldoff, who was successfully re-elected for another 3-year term. And we've got a new governor as well. Sophia Barroso Brucos is our new Wokingham governor. Unfortunately, our new WAM governor, Cora Wadsworth, due to unforeseen personal issues, she's unable to take up the role of governor, which is unfortunate. We've got changes to our, I've mentioned Megan Wright, who's our new Bracknell Forest partnership governor, and we've also got Councillor Pooja Bedi, which is our new Slough Borough Council representative as well. So a few changes to our governors.
Okay, thank you for that. Everyone, any questions? Okay, let's move on to item 6, NHS staff survey results, and I'll hand over to Jane.
Okay, good morning, everybody. For those of you who don't know me, my name is Jane Nicholson. I'm Director of People here at Berkshire Healthcare. What I'm going to talk about today is the staff survey. I'm going to assume everyone's read the paper, so I'll just give headlines and then give more time for a conversation. But just to set the context, staff experience is central to everything that we do. So we have a 3-year people strategy, and staff experience is absolutely central to that strategy. When I do induction, I explain that my role is to create, is to try and make sure that we have a culture where staff have a good experience and don't tolerate a poor experience. That's I really want to make it clear that we do look at our staff survey scores on a regular basis, and we also do a regular quarterly pulse survey as well in between to do a temperature check in between. So just to keep this very brief, because I'm conscious we've only got a little bit of time. Staff survey score 7.5. As soon as you start getting to those sort of levels of scores, then you are starting to get into world-class levels of engagement. 7.5 is hard to achieve and even harder to maintain. But as you can see from the papers, over the last, more than 5 years, we've always hovered around 7.4, 7.5, which I think is, something that we, are really proud of. And it isn't just that we're getting those scores with a small percentage of staff replying. You'll see that there are some trusts and providers that are getting higher, engagement scores, but have got much lower response rate or a much smaller number of staff. 64%. It's a slightly lower percentage, but actually, because our staff numbers have grown, we've actually had a higher number of respondents this year than we had in previous years. We've invested a lot over the last couple of years around leadership and also some of our work around anti-racism and the experience of our disabled staff as well with some of our neurodiversity work. We're seeing some of those improvements coming through in the leadership scores and the RES and the WDES scores that we have. That's the Workforce Race Equality Survey and the Workforce Disability Equality Survey, which draws information from the staff survey. And this year, what we've tried to give you, the trust, is a little bit more of a deep dive into the background and what might be influencing some of the scores that we've been seeing. Again, I'm not going to go through all the detail at this point because I think you've all had the papers, but I'm really very happy to try and answer any questions that you might have about that.
Guy.
Yeah, thank you. Thank you, Jane. Thank you for the presentation. On page 31 of the pack is the slide about the shortlist and offer rates for internal applicants.
Yes.
And I've got a couple of points on this. So the first table shows the likelihood to be shortlisted amongst different groups. And I just want to check my understanding for first point. On take, for example, the gender, male and female. Male 0.74, female 1.34. I guess that's okay if people are applying in those same ratios.
Yeah, and what our data is showing us is that you are more likely to be appointed. So this is about a ratio compared to the number of of people who are applying. So you are more likely at the moment to be shortlisted if you are female in the organisation compared to if you are male in the organisation.
Yeah, I think what I'm saying there is that's okay if females are more likely to apply.
Yeah. So what we have seen, I'm not sure about the actual numbers for our male and female colleagues, but we do have more females applying for roles in the organisation, simply because we have more females in the organisation. Nearly 80% of our workforce is female. We do know, for example, though, with our ethnically diverse staff, that our ethnically diverse staff are less likely to be shortlisted, but they apply for more roles. Whereas white staff, we know, only apply for less roles than our black colleagues or our ethnically diverse colleagues. Again, don't understand why that is. Maybe they have to apply for more to be able to be successful, whereas our white staff, maybe our white staff are more choosy about the roles that they apply for. We don't know the detail behind that. What we've got is facts that we need to understand.
Lovely, thank you. What is maybe more concern to me on that page is if we look at the disability, that sort of group. So likelihood to be shortlisted, there's sort of parity between non-disabled and disabled at about 1. But when we go across to actually being offered, disabled really drops.
And I think that's a factor of the fact that we have a guaranteed interview scheme for our disabled staff. So actually you will be interviewed if you tick the box and you meet the minimum criteria. Now, you may not have been the strongest candidate, and had you not ticked the disabled box, you might not therefore have been shortlisted, but you are guaranteed an interview.
Okay, I understand. Good to hear. Thank you.
All right. Anything else? Sophia.
Hello, hello everyone. I'm actually one of the new governors, and I represent Wokingham. So just
welcome.
Needed. Thank you. So just if nobody knows me here. I wanted to ask Jane about and something that Guy just said. So one of the things I wanted to point out is just I noticed that ethnic underrepresented staff and those with disabled backgrounds have lower satisfaction around promotion and leadership. And I understand that you said you're presenting facts, but is there something is going to go beyond just the facts at some point? Because I know that that is just not. I am in the higher education sector, and that's something that's also common. So what is something planned to be done after that? And then I had one question in relation to what was said in terms of the difference of more females applying than males, because that maybe I didn't notice in the survey, but does this go specifically to what roles the female apply? Because there is also the fact that females might apply at a lower level and males might be applying for roles that are at a higher level, more sort of senior level. So that is also something, I don't know, I can't remember. I don't think I noticed if that was that granular in the survey for us to capture that. And my last point was to do with neurodivergency. You said, and yes, organizations will allow for people who identify as neurodivergent, and if they meet the minimum criteria, to be interviewed. Are there any what is prepared for those with neurodivergency for the interviews? For example, some people like to have it's preferable to have questions in advance, etc. So there's a lot of research behind this. So allowing them to be interviewed might not just be. Thank you. I understand too many things.
I think there were 3 points that I got from there, so just correct me if I've got them wrong. I think you wanted to know what the actions were that we were taking following this information, a little bit more about that split between male and female, which I can probably take offline with you because we do have a deeper dive into the recruitment data, which I can send to you separately rather than going through that here, and what we were doing around neurodiversity for staff and questions in advance, which I can answer as well. So yeah, the actions here, as you know, we do have a anti-racism action plan, and recruitment and talent form one of the strands of work on our in our anti-racism actions. Likewise, we have been very actively supporting the neurodiversity strategy that was being rolled out across the organisation. We are aware that looking at the staff survey results, that some of the responses that we're getting from our disabled staff seem to conflict with the data that we've got. So we are talking to the Purple Network to try and understand, more about what is happening in that space for our disabled staff. So I can't answer the actual questions, until we find we deep dived into all of these pieces. But we are actively now, following through. If we find that there's something, and we try to act with curiosity and understand. On the interview questions in advance, everyone has a right to ask for the interview questions in advance on the grounds of an adjustment. So if you do want your interview questions in advance, you can do that. Some line managers, we give line managers the freedom to offer interview questions in advance if they want to. And I'm currently having a wider conversation within the organisation about whether we want to default that all of our, in all interviews, we automatically send interview questions in advance. But that's a conversation that's still ongoing at the moment, based around some data and understanding that we're getting from research.
Okay, Sophie?
Thank you. And just to clarify, the questions in advance were just an example. Part of the reasonable adjustments with people with neurodivergence. Thank you.
Yeah, no, I appreciate that. That's the one that we talked about, but absolutely, yeah, we'll look at ways that we can support, not just it's what they call the Barclays ramp, isn't it? You put ramp in because it helps someone with a wheelchair, but it also may help someone who's got a joint problem or someone who's got a pushchair. We put things in place and it helps more than that. It will help people with anxiety, for example, not necessarily people who are neurodivergent. So yeah, we are looking at ranges of measures and looking at ways that we can support staff to progress, without having to necessarily always progress through interview mechanisms as well. But again, those are bigger pieces of work that we're exploring.
Thank you so much.
Thank you very much. Ian?
Yeah, just a quick point on interview questions in advance. I mean, clearly it's not appropriate, nor is it practical to give all interview questions in advance. I mean, the key purpose of an interview is to see if someone will fit with a team, which is not necessarily an objective, specifically objective process. So you have to be able to ask fresh questions at interview that you possibly can't or wouldn't send in advance. And so I mean, that mustn't be a barrier, must be able to ask fresh questions at an interview. But secondly, the other aspect of that, of course, is a little bit of advice and support on how to ask questions to someone who may have an issue of some sort, whether that's neurodiverse, whether it's race or whatever. So, as important is just a bit of guidance to the interviewee. I don't mean certificates and training, but, just if you take a neurodivergent person who has a problem looking directly into people's eyes, sometimes it's just about looking to the side and not sort of that face-to-face thing. So just a bit of advice rather than always saying, well, let's publish everything in advance. So I think it's important to recognise that a big part of employing someone is not just about their skills, but is about will they be a complement and an enhancement to the team, which doesn't necessarily mean you should always pick the person with a superficially best set of skills.
And I think that you've encapsulated some of the debate that the organisation is going through, Ian, because at the end of the day, we need to find the best person for the job, and what is the right mechanism that we need to employ to make sure we can find the right person for the job. When we're interviewing, we're looking at the levels of, we have a values-based approach to interviewing, so we're looking at people who have not just the capability to do the job in terms of having the right qualifications and competencies, but also have the right behaviours and values in order to do that.
Yeah, I have to say I'm always nervous about this phrase "best person for the job" because I doubt whether there is ever a single best person for a job there. And as much as anything, what turns them into a good member of the team is how they're then managed when they arrive.
Oh, yes.
So, I think we should all move away from best person for the job because it covers up a multitude of sins. But otherwise, thank you.
No, I think, you're right. There can be multiple people that could do the job. They do them in different ways, but ultimately we have to make a selection, and that's why we have to talk about, who we think is most appropriate. If you don't like the word best, most appropriate to take the work forward. And one of the arguments, certainly from people who are neurodivergent, is that having the opportunity to have questions in advance and to be able to reflect on those questions gives them the opportunity to showcase what they can do, because properly, rather than just how good they are reacting in the moment. Because in most jobs, you don't have to react entirely in the moment. You're have time to think, you have time to go away and reflect on how you're going to approach something. So again, it's about how do we give people the chance to really showcase their abilities in the best way possible.
Yeah, because an interview is in a sense should be treated as an opportunity for understanding and to shine rather than an interrogation.
Yeah, absolutely. Yeah, 100%.
Okay, thanks.
Okay. Well, any other questions? Okay, I guess wind up. But I mean, this is two things I wanted to say. One was that this is an outstanding set of results. So, fourth highest in the country of all trusts for engagement, etc. This is outstanding performance, and it's sustained outstanding performance. So that's really great. The second thing is, I think, coming to your point, Sophia, is that a trust has been absolutely determined to make sure that all staff of whatever category you put them in, gender, race, disability, etc., are able to shine and really fulfill their careers, both personally and professionally in the trust. And of course, we're learning all the time. So things aren't perfect, you never get that perfect, but we're continually learning. And I'm sure Jane will share with you, Sophia, some of that work going on, and you can observe it in the board papers and the board discussions. So you can be assured that we're not resting on our laurels. This is a continuing progress. And I think our anti-racist program we launched, was it last year? I can't remember. Has really made some progress, and you can see that in the results. Now, we're not there. We know there are things that are not where we want to be, but we're certainly the things are moving in the right direction, which is very satisfying. So we certainly don't give up. We certainly don't rest on our laurels. This is a continuing journey, but I think we should also celebrate the outstanding results that the trust has got so far. So with that, if I may, I'll finish. But Julie, are our colleagues on the One team available, or?
Yes, they are.
Oh, okay. Hello.
We're all here.
Thank you. I'll say goodbye.
Okay, thanks so much, Jane. Perhaps we can move on then to One Team.
Right, hello. I'm kicking this off. I'm Jane Reynolds, for those of you that don't know me. I'm the Director of Operational Development, currently doing an interim role into mental health as Divisional Director. One Team started in 2022. It was started as an idea based on the fact that we knew our mental health services were, once people were into them, they got a very good service. That was the feedback we were getting. But getting into them and knowing what you were going to get was quite difficult. So we did start a piece of work on One Team back in July 2022, so quite a long time ago. On the call today, you've got myself, you've got Ruben Pierce, who's one of our lead consultant nurses, Sue McLaughlin, who's our senior consultant nurse in mental health, and Colette, who's our lead psychologist. And they'll be doing most of the talking, you'll be pleased to know. But because this has been driven, and as we carry on forward, is driven by the clinical voice. So can we go to the next slide, please? So this is just the aims of what we're going to talk you through today. So I'm not going to go through that because you're going to feel it as we go through. So, but we'll send out the slide pack to you all. Could we go to the next one, please? So just to remind those of you that don't know about One Team, and I wonder where you've been if you don't know about it at all, because we've been talking about it for quite a long time. We needed to look at the long-term plan and the community mental health framework and make sure our services were actually, mental health services were actually reflecting that vision, that national vision and an internal vision. And we wanted to develop a new model of primary and community mental health care for our patients and through transformation, so that it was easier to get into our services. So that easy in that we talked about when we first launched this, so that people wouldn't feel, they'd know exactly where to go and they'd know how to get in. Once they were in, that the offer would be very clear to them. There would be a clarity around offer. They'd know what they were getting. They know the expectation. And then what we called easy out. So getting out of the system, mental health system, back into normal life, if you like, and stepping off into services that could support that return. And this meant to reduce boundaries, because boundaries and barriers were absolutely endemic in our services at that time, and we recognised that it was really difficult for us to navigate. So for a patient or carer to navigate, it was almost impossible. So we needed to address that. And we also knew that across the 6 localities in Berkshire, your experience would be very different according to which one you went into. So that unwarranted variation. Why was the variation? Why didn't we have one offer, one way of getting in, one way of getting out? And we needed to improve patient, staff and carer experience of the whole journey, and to involve them in that journey. So we did a lot of stakeholder work as well. We wanted to support delivery also of the personalised approach to risk and care planning with a national move away from CPA, which is the care planning approach. And we wanted to learn from PSIRF. I have actually updated these slides so that you know what that means. So that it's Patient Safety Incident Response Framework. So we needed to address that as well. So those were the aims. Could I go on to the next slide, please? Because this is what we've done to date. So 3 years. We've done a lot more than this. This is it's been at times painful, but at times really, really fulfilling as well. So we've now got a new model for triage and assessment, and the assessment is called One Assessment. And it's the assessment that we add to as patients come in and out of our service. So we never repeat it completely again. It's add to. We've got a common point of entry model with CPE, where they do all the triage. They have navigators for those patients that don't need a service from either the mental health team or our mixed service that sits in primary care, but they do need a little bit of support, and it might be support about a housing need or something like a financial issue, or something that the navigators in the common point of entry can deal with, and they will deal with it at that point. It may also be that they come through triage and they need a crisis service, and so they'll be pointed to crisis. For those of them that don't need any of that, they will go through to our one team assessment, which is managed by the multidisciplinary team at Place. So that's the model. And then once they've had that assessment by whoever does that assessment, it will define what the offer is going to be, and the patient will be made aware of that. whilst they're sitting waiting for that assessment, and we have reduced the wait times for assessment. I've got the figures with me today, but it is coming down. Everything is now digitalised as well for mental health, so everything is on Rio, and which means that we can now get off outcome data from that system as well, which is really, really important. And so whilst the figures might not be startling to you when you see them, we actually now know what we're dealing with, which we didn't know before. So I just wanted to drop that in there. And that stop the clock is around that. So digital flow and process for stopping the clock. And that's a national term. When you come into a service, you should have 28 days between coming into the service and having that assessment and being seen. So we're working on that to make sure people get that. The clear and consistent treatment offer is being rolled out across, and that's being led by Bridget Gamal, who's our lead psychologist for the Trust. And we've got a new approach to risk formulation, named worker and safety planning, and Ruben and Sue will be talking about some of that. We've got an older people service that is currently underway, service review, because initially they weren't as involved in this as they could have been. So we're now doing that piece of work with them, and we're doing a waiting list review and the merging of the mixed and CMHT teams internal referral. So it is a one team. And the one person I failed to mention when I started was Karen Watkins, who leads the programme management office in the Trust, and her team and digital team led by Kate Hart and Bill Johnson previously. Have been pivotal in this piece of work. It really has been a one team throughout the Trust to get this work done. So I think we just need to mention those people as well. I'm now going to pass over to Ruben and Sue to do their piece, because I've talked enough, and we'll have questions at the end. Thank you very much.
Thanks, Jane. Morning, everybody. So just to build on what Jane said, one of the pivotal things in all of this work, once patients have come into the service and had that really thorough one assessment, we've used the outcome measures, and we know what the treatment pathway is, it's really important that the patient and their family have that information and they know what's going to be happening in a really robust care plan. Some people may know that historically we used the care programme approach. That was often 27 pages long. The system we've moved to now is a much more streamlined approach, and we've worked nationally on this. It's not a model that Berkshire Healthcare have developed. It's something that's a system-wide model. The new guidance is still out for consultation from NHS England, but we've gone ahead and we've designed what we think is going to work for patients in Berkshire based on patient feedback, based on the learning that we've had from when things haven't gone well. So we've got that new system up and running now. It is early days. We are collecting staff feedback. We've got some patient surveys that are due to start in July. So we will probably refine it based on that feedback. The other important thing for us is making sure that we're keeping vigilance around, is this system working? Are people getting what they should be getting? So we've got some data dashboards that I'm going to show you a bit later on to really help us keep an eye on this. Next slide, please, Ruben. The other important element is we've moved to a personalised approach to risk. So what that means essentially is that we've moved away from categorising risk. So we no longer use low, medium and high categories when we're talking about risk. And instead, what we try to do is describe the needs that the person has in relation to their risk. Think about what elevates risk for them, but also what mitigates risk. And importantly, what we can do around safety planning to really support that. And what that does is it prevents that differences of opinion about thresholds, because we know that different people will think risk is low or risk is high, and that could often be a barrier to people accessing services. So we've got that really good narrative now. We've had to significantly change all our documentation, training, and also work very closely with service users, patients and carers, because it's a very different conversation for them as well. And again, we need to make sure that what we're doing is actually being implemented in practice. So we've got our compliance dashboards, we've got our real-time surveillance dashboards, so we can pull learning from when there's been a death. We've also set up a panel, a safety panel for carers. And that was based on a lot of feedback that we've had, especially when things don't go how we want them to, that carers' voice wasn't heard, their concerns about risk wasn't heard. So we've got this independent panel now, and that's an opportunity for carers to be able to bring those concerns. And again, we've got a staff survey live, we're collecting patient feedback, and we're going to be rolling out. We've rolled out a lot of training to our own staff in the CMHTs, but we're also rolling out training now in talking therapy, and Ruben's going to talk a lot more about the training. Next slide, please, Ruben. Next slide, please.
Sorry, Sue.
It's all right.
Yeah, there we go. Sorry.
I don't think it's moving on ours, but I can just talk anyway without the slide because I know what's on the next one. So we have had patient feedback about all of this, and I've got a couple of quotes to share with you. Oh, here we are. In terms of that relevant history that Jane mentioned right at the beginning, I think this quote really sums up the impact that that's having. People are finding it so much better than having to repeat and relive that history at every step like they would have had to previously. People told us that they often found that would often take up time in the session and leave less time to really be focusing on what they needed. So I think that's given us assurance that we're going in the right direction with this. The other feedback we've had is around that personalised approach to risk and moving away from the categories, and people feeling that is, it's much more person-centred, and it avoids that exclusion from key services. For example, someone at high risk might not be able to access talking therapies, and moving away from that, it gets rid of those barriers. There's still a lot of feedback to collect. There's still a lot of work to do, but I think we're going in the right direction based on the feedback that we've had so far. Ruben's going to talk now a little bit about the training. No, he isn't, sorry. Because we've changed things significantly within the services, we've had to put in some blanket rules around our expectations. These are things that must always happen on the patient journey. So one of the big important things is us really striving to reach that 28-day referral to treatment target. So we're putting a lot of focus and emphasis on that. The easy in to services that Jane mentioned, again, that's getting rid of those artificial barriers that were often there, and having that really good MDT discussion if there is disagreement, or if we're finding that people are moving around the service unnecessarily. Getting rid of the variation across the different localities within Berkshire, and just making sure that people are getting really consistent delivery of that evidence-based offer. The named worker, I've told you about. Everybody receiving treatment for SMI will have that named worker and the care plan. And we've got that really clear step up and step down process, so we can make room in the system for new people coming in. You're not in mental health services forever, because that's quite a hopeless message. Next slide, please, Ruben. Just to show you an example of how we're monitoring all of this. So we've got some really good dashboards set up, and we can see, but also the services themselves can see how they're doing. For example, with the named worker, with embedding the named worker, where we are in terms of our compliance with all that new risk documentation that I told you about. Really important that we're making sure that all these new things are carefully monitored and that they're happening in the real world of practice, especially when it's very new. So these are really helpful. We're also developing dashboards so we can see perhaps who's using crisis services and calling on that type of support in case we need to put in a more robust safety plan. So really using the technology to help us with this work. Next slide, please, Ruben. And it's over to you, Ruben, now.
Thanks, Sue. Sorry, I momentarily lost control there. So in terms of sort of training, it was important to sort of do a bit of a training needs analysis to help us identify any gaps. And that allowed us to refocus and build on our existing sort of workforce strengths. So we've developed a sort of multi-layered training offer. It combines psychosocial interventions, psychological, pharmacological, and physical interventions, alongside some core training that everybody gets, and some training around some of the digital tools staff will be using. And the aim of this is to give clinicians a sort of toolkit, I suppose, of interventions they can draw upon when they're supporting patients and families, that cover that full biopsychosocial model, and interventions with a clear sort of beginning, middle and end that can be measured and evaluated for effectiveness, hopefully providing a lot more structure, or providing staff with a lot more structure to what they're doing, and therefore structured to patients and families in terms of what they're receiving. As Sue's already mentioned, we really wanted to reduce the burden of documentation, and within that sort of move away from some of the sort of checklist approaches and things that have crept in over the years, which I think had been obviously put in to sort of standardise our approach, but in some ways had got in the way of that patient clinician sort of relationship at times. So what we hope to see is a more of a focus on sort of the relational, values driven and personalised approach to care, and so it feels more sort of human and responsive to individual needs. So at the heart of the training is a real emphasis on therapeutic use of self, how we communicate, how we try and understand somebody's experience, and then use that alongside these structured interventions that can contribute to somebody's recovery. Do the next slide. So sort of underpinning the training, we've got this sort of core set of values, which are sort of trauma-informed, being culturally competent, neuro-inclusive, and co-produced. So we focus on that, as I say, that practical application of the evidence-based skills, and we try and bring that to life in the training through co-produced plays. We use sort of video scenarios that we hope feel real, because they're sort of based on real experiences of both staff and patients and families, and therefore sort of personally relevant. And staff are supported to try out and rehearse the skills in a safe place, and obviously observe others and give and receive sort of constructive feedback and grow together as a cohort in the training. Alongside that, we wanted to invest in supervision as well, because often, as you know, we can go on a training course and it can feel wonderful, and it may sit with us for a little while, but it's around how we help staff translate that into their practice on an ongoing basis. So there's follow-up supervision in much of the training that's on offer, where staff who are a part of that cohort can come back and think about that implementation of the skills in practice with that same group of people, so it feels sort of safe and so on. And also people who have undergone the training, we hoped, and through our sort of clinical leadership, through our psychological leaders, our nursing leaders and so on, we hope to embed those core values and that learning in our complex case discussions, our MDTs, our sort of coaching day-to-day staff. So we hope that it sort of cascades learning through that role modelling and sort of helps grow that capability in a sort of sustainable way, and hopefully contributes to staff feeling more confident, competent and accountable for their practice. So I just wanted to give a bit of emphasis on the clinical decision making and what we're sort of doing to help staff stay attuned to some of the real important threads that run through care provision, and they're sort of represented in this ball of wool, which we're using in a lot of our training offer, and it really just represents something that can be quite difficult in practice under all the sort of pressures people are under, is to really think about unraveling that sort of historical information, what families are telling us, what the patients are telling us during an assessment, and those important threads we need to consider when we're thinking about their care and synthesising that information and bringing it all back together into a sort of formulation that can inform the care planning, risk and safety management. And staff seem to have connected to this ball of wool. It kind of makes sense. So that's sort of unraveling and then bringing back together. So as well as the sort of best practice guidelines and stuff that inform the training, we also use, as Sue mentions, live data from things like our suicides, our sort of live suicide surveillance dashboard, new insights as they emerge from our governance and patient safety teams. And it's a continuous sort of ongoing change, and we month to month, as the training is delivered, we update and keep it very live. So in terms of what staff are telling us about the training, we've had about 150 so far people go through training which utilises this new approach. So that includes our clinical risk and our psychosocial interventions training. So lots of people feeling more confident off the back of it, feeling more they're able to be a bit more effective in their role. They felt sort of valued in the way it's been facilitated. So I think the sort of interactive way of delivering training has been helpful. One of the more of the challenges, I suppose, has been again, with all the sort of pressures, is time to be able to get onto the training and stuff, because it's more of a time investment to be able to cover what we want to cover. But we're working with our heads of service and stuff to find ways of freeing people up to be able to attend. I guess, as I say, we hope we'll see an improvement in confidence and skills, competence, and hopefully better outcomes in terms of experience and services and incidents and so on. I guess it's a long-term investment. We want it to be sort of baked in or embedded, and so a lot of this is delivered in-house by our sort of leading clinicians. I guess we'll see. Hopefully, we'll have some more to report in the future, but so far it seems to be going well. Thank you, and I'll hand back over to Sue now.
Thanks, Ruben. So really now, just to sum up the new model and the impact on the prevention of future death. We know from patient safety reviews, for example, the Forbury Gardens, there was a focus on a lack of robust MDT assessment, that really proactive, assertive outreach approach, particularly when there's disengagement or particularly when there's psychosis and substance misuse and alcohol misuse. There was lack of clarity often around the pathways Jane alluded to at the very beginning. And there was a lack of joined up working, multi-agency and not listening to carers. So we've really tried, we know we can't eliminate all risk, but our ambition is that people will be able to say Berkshire Healthcare did everything they could. We got a really good service. And that's really our sort of driving force. And we keep constantly asking ourselves, what difference is this going to make in that situation, or will it be different for that patient if they present next time? So it is very much around that clear care and safety plan, focusing on the target problems. As Ruben said, that really meaningful connection, not the checklisty approach that patients find really disempowering. Having that really good clarity and oversight, the face-to-face contact, outreach if people are disengaging, and we've got a whole focused work stream on assertive outreach and what that's going to look like. much more MDT oversight. We've mentioned the integrated multidisciplinary team meetings that we've got after our one assessment. Ruben's already talked about the staff skill and confidence. We've got the carers' concern about safety panel that I've mentioned. And there's a big programme of work in the Trust around preventing harm to others. And that's involving our MAP colleagues, working closely with prison referrals and making sure we've got really good systems so we can escalate those people who might be presenting as harmful to others, making sure that they don't slip through the net and that we're really joined up. And Gwen Bonner, one of the other nurse consultants, is leading on that work stream as well. I know we're running out of time, so I'm going to hand over now to Colette, who's going to talk about the psychological provision. Thanks, Colette.
Yes, Sue, thanks. And I'll be very brief because I think we probably have gone over our allotted slot. So I will quickly take you through some of the major changes we've made to community adult mental health psychological provision over the past year and some of the impact that this has had for patients. Next slide, please. So I think, we're all aware of the challenges post-pandemic and in tandem with the cost of living crisis, the pressures that this has put on services, particularly mental health services. This resulted in quite long waiting times. There was a much higher level of acuity than we saw in the past. And what we began to be really aware of was that there was quite an unsatisfactory patient journey for many patients. We were seeing some patients having multiple assessments, which we know can be re-traumatizing for people. We were very aware of quite a siloed working ethos with patients being, quote unquote, bounced around between services, and of course the unwarranted variation in offer and provision. We also increasingly became aware when we were looking through patient data that there was more often than we'd like non-adherence to evidence-based psychological provision, and that there appeared to be gaps in knowledge and skills for some clinicians. But this was all exacerbated.
Your sound's gone off. Oh.
With regard to Sorry. Shall I continue?
Yeah, please.
Sorry, I think. Okay. Particularly in relation to activity and outcomes, patient outcomes. Next slide, please. So, based on all of this, there was a decision to redesign adult mental health psychological provision. In line with some of the one team ambition that Jane was talking about earlier. And particularly, we were interested in improving the patient journey and providing good quality, evidence-based, trauma-informed care. So the community CMHPT, Community Mental Health Psychological Therapies provision was initiated following staff consultation in April. And yes, we set out our stall. We got going exactly a year ago in June 2025. So we've been going for a year. The team includes psychological capacity from across the CMHTs, across the MHSs in all 6 places, early intervention in psychosis, MIX, the Mental Health Integrated Community Service, and CREST, which is the Community Rehab Enhanced Support Team. A lot of the work has been around revising structures, systems, and processes. And in essence, what we now have is a centralized waiting list across all services, which of course allows for a lot more oversight. We have much more flexibility in delivery of the offer. So, we have clinicians able to work across places, and we're very much catering to patient choice. We have much more assurance that an evidence-based intervention is being provided by clinicians with appropriate knowledge and skills. Next slide, please. So just some examples of the really significant improvements that have been made in just 1 year. We've almost halved across the MHSs, the CMHTs, we've almost halved the waiting times. That slight increase over the past few months is down to one patient outlier that we've been able to manage. So we are hoping that certainly we will stay at the 10-month mark and work to even improve on that. So that, that's been a real improvement in terms of waiting times. And next slide, please, Ruben. EIP, similarly, you can see that there has been a really big improvement from 17 months down to 10 months. And certainly if you look at that ongoing and consistent improvement in the number of patients waiting for treatment and assessment, that's been really noticeable. Thank you very much, and I'll hand you back to Sue, I think, for any questions.
Thanks so much, Colette.
Thanks, Colette. We're happy to take any questions, Martin, if there's time.
Could you unshare just so we can see you all properly? It's beyond my competence. That's great. Thanks so much. Yes, James, question.
Yes, hello. I hope you can hear me, because yeah. I'm using some new headphones, and some people said they're having issues with the sound.
Fine.
So first of all, if you can hear me, great. First of all, I wanted to apologize for being slightly late. I thought I had saved the links yesterday evening, but it didn't seem to be working this morning, and then Julie resent it to me so kindly. So I want to give first of all a very warm welcome to the new governors. Welcome on board. And now regarding this service, my question was, it looks fantastic, of course, from the perspective of the presentation and what's being done, and mostly within the last year. But I know quite a few people, like on that slide where you had the patient feedback, that had long ongoing requirements to resort to the mental health services, and they've been quite disappointed in the past, even who've resorted to talking therapies, saying that the first few calls always were online. They might not even be so technically savvy, and often they seem to be exactly more of an exercise of ticking boxes. And someone who's really desperate felt it was a completely unpersonalized approach. So I was wondering how people can actually access this service, especially if they've had some kind of history already with the NHS regarding mental health, and feel disappointed at the kind of support they may have had in the past. If in order to have access to this new service, it is something that they can refer themselves to, they need to speak to their GP first. So what would be the process if someone feels that they've been let down in the past and they really would like to or have hope of having some new kind of support now regarding their mental health issues?
Yes, so the actual process of accessing the service, James, is still the same in terms of that common point of entry. And it wouldn't be a barrier to accessing the service if they've had previous bad experience from our point of view, but I recognise it probably would be from theirs. So we would hope that they'll experience the service in a different way, but the access is still the same through our common point of entry, and that could be through their GP or through themselves, self-referring, and similarly with talking therapies, the process of accessing the service isn't the same, but we hope the experience is much more streamlined.
Yes, I understand that this is a very recent process that's being implemented, and I think the people I've heard this kind of feedback from, it's regards 2, 3 years, 4 years ago. So as I said, as this improvement is being being implemented and taking place, so you would advise them maybe to go and talk to their GP, saying they feel they still need some kind of face-to-face mental health support, and they might then refer them again to this particular type of service. Yes.
Absolutely.
Yeah.
Sorry.
Okay, so we have, although the point of entry, common point of entry is still the access routing, James, we have now got very much pathways from that. So if you're already known to services, you'll be fast-tracked back through to the place. So you won't have to go through your history all over again. There'll be a fast track in. Similarly, if crisis response team puts you in, or talking therapist, we've developed a fast track route for those people. So you're not having to tell your tale more than once. You go back back in quickly. So there's a quick access route, because that's what the Easy In was about. You know, for somebody that's been in the service for several years in and out, we didn't want to make it really difficult for them to get back in. But equally, you know, at the end of it, we want it to be easy to get out as well. So we have now got a very clearly defined pathway, and we're constantly tweaking it due to feedback. So if we get feedback from someone that it's not working, it's changed. It's had several iterations in the last 2 years. It probably have several iterations in the next 2 years, because that's what life's about, isn't it? Change. So yeah, we can share that with you. We've got that pathway, but it is evolving. So what I give you, if I give it you to today, I can guarantee in a month's time it'll look very different. So okay.
Yeah. Well, thank you very much. I mean, that's what Buddhism says. The only reality in the world is impermanence, isn't it? But hopefully evolving for the best. and that's what the kind of thing I want to hear, if there was some kind of fast tracking, if you already had that history. Thank you very much. Yeah.
Thanks, James. I'm just slightly conscious of time, so if you can try and make the questions quickish, that'd be nice. Fiona.
Thanks very much. That's a really interesting presentation and really helpful. So just a little bit of feedback in terms of the voluntary sector. We as a charity have found it much easier to use the common point of access, much better response, much more positive, much more treated like professionals. So thank you for that. I don't think the word has got out there within the voluntary sector generally about it though. So I think there is a piece of comms work to be done there that you might need to consider. And the second question is, how much voluntary sector involvement have you had and where you currently are? And certainly I've seen some in Reading, but not across the other areas in Berkshire. So again, there might be a wider comms piece that might need consideration. And the third thing is, as you mentioned in your last slide, some of the common areas, including anxiety, depression and eating disorders. Can I just ask where hoarding sits within that? Because we are seeing a large number of older people coming through with hoarding issues.
Should I take the first two, and then I'll leave it to Ruben and Sue about the hoarding, and Colette? So the first two, first of all, voluntary sector. We did involve a lot of people from the voluntary sector in terms of the stakeholder mapping we did. There's 400 names on the stakeholder map, Fiona, and it's several. Any names that we could gather from anybody we sent to, and there's a lot of voluntary sector people, but we probably didn't grab everyone. So if there's any names that you can share with us, please share them with us. We've got a one team inbox, and you can share those and we can add them to that stakeholder group. In terms of doing more work, we have got a stakeholder event planned. I think it's either September or October. Karen's on the call. She'll let me know if I've got that wrong. And what that's about is to actually showcase everything that's been done over the last 2-3 years. So it would be really important to have as many names as possible, because what we do is, for those people that can't make it for any reason, we don't have enough space, we can then send out the presentations and everything so everybody can see. And also we do a newsletter. We continue to do a newsletter for one team. So again, if we have names, we add all of those names to that newsletter distribution. So again, it'd be really useful to have any. But you know, there's a lot of people out there. We've got as many as we knew about, but any that we don't, any help we can have with that, we're more than happy to have more names. But that answers that bit. I'll leave the other bit, the hoarding bit, to Ruben and Sue.
I can.
Oh, Sue, go on quickly.
Sorry, thanks, Fiona. Yeah, we do include hoarding now when we're thinking about risk, and it is a category that we focus on in the training, and of course we link with our colleagues in adult social care as well around interventions, recognising that it has significant impacts. I don't know if Colette wanted to say anything more about the specific psychological treatments.
Yes, we do. Hoarding does sit with on our anxiety disorder clinical offer, and we have the Frost and Steketee model, which is the evidence-based model for hoarding. So it's definitely up there.
Thanks very much.
Thank you.
Okay, can we move on to Guy? Then we'll move on to the next item.
Yeah, thank you. I often hear the term used in the trust, evidence-based training and evidence-based interventions, but I'm just wondering whether that maybe, and I totally get that, but I just wonder a bit whether it sort of holds us back sometimes. Do we ever take a risk, safe risks, in the patient's interest, in, for example, using medicines off-label?
Yeah, that does happen. I think it has to be carefully considered, Guy. But we have a sort of message in training: try any angle. You know, if something's not working, even if it's evidence-based, don't dogmatically keep repeating it. So we do try things. We do take risks. We also have to be mindful as well of the other side of that. You know, we did get ourselves into a bit of a situation where we're just repeatedly offering things to people endlessly without really seeing any good impacts. So of course the offer has to be evidence-based, but if it's not working, being pragmatic and trying other things. And medical colleagues will often use medications that are not necessarily on label for a specific treatment, particularly personality disorder related issues.
Lovely, thank you.
Thanks so much. In which case, thank you to the T1 team. It's a very interesting presentation, great work. So thanks so much indeed. I'm afraid we now have to move on to a really exciting thing on the. I'll hand over to Julie.
Yeah,
thanks, Martin.
Thank you.
Thank you. Bye-bye.
This is a very light touch review of the Constitution, but it's literally because of the Procurement Act. So experienced governors will know that every so many years we do a really thorough review of the Constitution, and I'm suggesting we hold back from doing that until we've had all the changes through the NHS and also, you know, new chairs. So we will do that. So this is just literally to keep the Constitution in line with legislation. So I'm asking governors for their approval to the changes, and if approved, they'll go to the Trust Board next month.
Everyone content? I'm assuming you are. No one's shaking their head. Thank you very much. Okay. So committee steering groups. I think if we could take the papers as read, but I don't know whether the chairs want to just raise anything as we go. Membership.
Nothing to add beyond the paper, Martin.
Thanks so much. Any questions? Okay. Equalities, Sarah. Sarah's here. Okay, well, the report's there. And living life to the full. Okay, well, thank you for those reports. And right, next one is Chief Executive's report. The patient experience quarterly report. I don't know, is Liz Chapman here? Or is, I think
it's Trevor Lyle, he's here.
Okay. Trevor?
Morning, everybody.
I think if we take it as read, Trevor, and just pick out some key things you want to raise.
Will do. I'll just share the report with you. Just bear with me. Okay. Right. So this is the patient experience report Q4, 2024-25. Yeah, as Martin said, Liz couldn't make it today, so I'm attending in her place. I don't have the same breadth of insight as Liz does, so if we have any queries or concerns and I can't answer them, then we'll take them back and we'll provide a response within the minutes. So moving on. So this is the overview. A lot of data there for you to digest. Some patient numbers. I want great care, formal complaints. Local resolutions, yeah, that's something that PALS is frequently involved in. I work closely with our complaints team, and we very often look towards a local resolution, which would probably be in the best interest of the complainant. So that's something I'm frequently involved in. Yeah. So there's quite a range there of of data for you to digest.
Trevor, would you like to take questions? Is it probably easier?
Yeah, sure. Yeah.
Okay, so I think governors have had all the paper, so I guess whether there's any questions, Guy.
Yeah, thank you. On page 61 of the main papers, it says, and this is just a small thing, it's about mental health inpatients, the wards. I picked up on this area just because it's one of the areas which I support in my day job. And I noticed the response rate for I Want Great Care is over 100%. Now, on the next page, it does explain, there is a paragraph explaining that, but I still don't totally get it. Do you know, please?
That's something I'll need to take back, Guy, I'm afraid. But what I'll do is I'll take this back and we'll respond to that within the minutes, if that's okay.
So, yes, of course. Thank you.
Any other questions? Well, I think the paper actually is pretty clear, the executive summary. So I think if that's all right, we'll move on, Trevor.
Yeah, sure.
We'll move on to Chief Executive's report. Julie, I'm going to take questions.
Yeah, good morning, everybody. New governors, I'm Julian Ems, Chief Executive. Welcome. And Martin, yeah, the report as is, there's some explanation to some of the performance stuff as well, in terms of sort of brief narrative. And let's just open it up for any questions or comments.
Thanks for a chance to Guy.
Yeah, thank you. On page 116, the staff assaults, it's quite alarming to see how much it's gone up. And I see that we're collaborating with other trusts to see if we can bring that down. So it's just a comment. It's good to see, and hopefully something will come of that.
Yeah, it is. It's a complete area of focus for us. It does tend to fluctuate in truth. You'll never get it kind of linear, partly because it's often associated with a small number of patients as per that kind of description on 117. But we know through the right therapeutic interventions, the right therapeutic milieu on the wards, that we can actually have an impact on much violence and aggression. So it is continued focus for us.
Thank you.
Any other questions? No?
Thank you, Martin.
Okay, thank you very much, Julian. So to start getting governor feedback now, item 11, any things which you have been engaged in or aware of that you'd like to share with fellow governors? Okay. Any other business? Oh, sorry, Madeline.
Sorry, my microphone was off.
Oh.
I wanted to mention under the reports from the committees that the next Living Life to the Full meeting, we have invited the managers from ABRI, Community Engagement and Housing, are coming along to that meeting as the speakers to talk to governors about possibly much more collaboration between the housing officers and mental health patients and their needs for housing.
Excellent. Thank you for that, Madeline. Sounds very interesting.
Yeah.
Thank you. Okay. Well, the next meeting is the 16th of July, extraordinary meeting to appoint the new trust chair. So that's the 16th of July. And I think, unless Julie reminds me of something I've forgotten, I think we call that the end of the meeting. In which case, thank you very much. And as always, when you reflect on the meeting, it's good to hear any comments you have about, whether it meets your requirements and anything we can do. But I think there's some interesting stuff there. In which case, thank you very much, everyone. Enjoy the rest of the day.
Thank you.
Thank you very much.